According to the American Heart Association, nearly half of all American adults, about 122 million people, live with high blood pressure. And here's the striking part. Around 75% of them rely on medication to manage it. Yet medication alone isn't controlling the condition. Each year, more than 675,000 Americans die from complications related to hypertension, even while taking their prescriptions consistently. I'm Dr. Michael Kent, and after more than 20 years in cardiac surgery, I can explain why these treatments often fall short. The reason is simple. What you've been taught about high blood pressure is fundamentally incomplete. Most people are told that hypertension is a plumbing issue, too much fluid volume in the circulatory system. Physicians often recommend reducing sodium intake and using diuretics to eliminate excess water. As fluid volume drops, blood pressure readings improve, and it appears the issue is resolved. But in reality, it isn't resolved at all. That entire approach is based on medical thinking from decades ago. It's outdated, incomplete, and somewhat misleading, leaving millions of people unwell despite having normal numbers on their monitors. The truth is far more complex. Hypertension is not primarily a fluid problem. It's a structural one. It involves the blood vessels themselves. Your arteries are not just overfilled. They are damaged, weakened, and stiff. They undergo structural changes at the cellular level that medications cannot repair. When I perform bypass surgery and examine the arteries directly, the difference is obvious. A healthy artery is elastic. It rebounds when touched or cut. In contrast, an artery affected by long-term hypertension feels rigid, almost like cutting into hard material. It is stiff, calcified, and inflexible. That stiffness is what hypertension truly reflects. Medications may adjust the pressure readings, but they do not restore the vessel's natural flexibility or repair underlying damage. By the end of this video, you will understand 4 hidden mechanisms that contribute to hypertension and a clear 4-step approach designed to help reverse this damage at the structural level. This is grounded in cellular biology and biochemistry. To begin, let's look at what hypertension actually means at the cellular level. Your arteries are highly complex, living structures made up of 3 distinct layers. The innermost layer, the one directly in contact with circulating blood, is called the endothelium. It is an extremely thin layer of cells, even thinner than tissue paper, lining every blood vessel in the body. Despite its size, it plays a critical role. It is not just a passive barrier. It acts as an active metabolic organ. It produces chemical signals that regulate blood flow, prevent unwanted clotting, control inflammation, and support overall vessel health. The endothelium also has a protective surface layer known as the glycocalyx. You can think of it as a nonstick coating on the inner walls of your arteries. This layer is made up of sugars and proteins and is only a few micrometers thick, too small to see, yet essential for cardiovascular function. Research published in Pfluger's archive in 2007 showed that the glycocalyx serves several key roles. First, it creates a smooth, low-friction surface that allows blood to flow easily. Second, it blocks inflammatory molecules from attaching to the vessel wall. Third, it detects changes in blood flow and signals the endothelium to release nitric oxide, a gas that helps blood vessels relax and widen. When the glycocalyx is healthy and intact, blood vessels remain flexible and efficient. But when it becomes damaged or breaks down, problems begin. High blood sugar, chronic inflammation, smoking, and oxidative stress can gradually erode this protective layer, much like acid stripping away a coating. Once it is compromised, the vessel wall becomes exposed and vulnerable. Inflammatory molecules begin to stick to the endothelium. White blood cells attach to the surface, and LDL cholesterol particles start to penetrate the vessel tissue. Atherosclerotic plaque begins to form. The endothelium no longer produces enough nitric oxide. Your vessels tighten and lose flexibility. Blood pressure rises. This is the first mechanism of hypertension: glycocalyx damage and endothelial injury. Here is the key point. No blood pressure medication restores the glycocalyx. ACE inhibitors do not fix it. Beta blockers do not fix it. Calcium channel blockers do not fix it. Diuretics also do not repair it. These medications help control the numbers you see on your monitor, but the root damage remains unaddressed. As a result, your blood pressure readings may appear controlled with medication, yet your vessels remain impaired, still at risk, and quietly progressing toward a stroke or heart attack. This helps explain why individuals on blood pressure medication can still experience cardiovascular events. The treatment manages the symptom, not the underlying cause. Now, this leads to the second mechanism, arterial stiffness and calcification. Many physicians overlook this. They often focus only on blood pressure values and not on whether arteries are flexible or stiff. However, this difference is more important than the numbers themselves. Research published in the Journal of the American College of Cardiology in 2010 showed, through systematic review and meta-analysis, that arterial stiffness predicts cardiovascular events and overall mortality more accurately than standard blood pressure measurements alone. Blood pressure is expressed as two values, systolic over diastolic. The gap between them, known as pulse pressure, provides insight into arterial stiffness. Normal pulse pressure ranges between 40 and 50. As arteries become stiffer with age and disease, systolic pressure rises while diastolic pressure falls. For example, a reading might be 162 over 72. The systolic value is high, the diastolic is lower, but the pulse pressure is 90. A wide pulse pressure, anything above 65, suggests that the arteries are stiff and possibly calcified. The aorta may have lost its elasticity and its ability to absorb pressure effectively. A 2006 expert consensus document published in the European Heart Journal confirmed that arterial stiffness can be directly measured using a test called pulse wave velocity. This test evaluates how quickly a pressure wave moves through your arteries. In healthy, flexible arteries, the wave travels slowly, about 6 to 7 meters per second. In stiff or diseased arteries, it moves much faster, around 12 to 15 meters per second. The higher the wave velocity, the stiffer the arteries and the greater the cardiovascular risk. This test is non-invasive, widely available, and takes about 10 minutes to complete, yet it is rarely ordered in routine practice. Why not? Because there is no prescription medication that directly fixes arterial stiffness. Research published in the American Journal of Hypertension in 2004 explained the effects of vascular stiffening on systolic blood pressure, noting that current drug treatments do not address the root structural issue. Let's break down what causes arterial stiffness at the tissue level. Your artery wall is made up of 3 distinct layers. The middle layer, known as the tunica media, contains smooth muscle cells and elastic fibers. This layer gives your arteries their flexibility and allows them to expand and contract properly. However, with aging, especially in the presence of hypertension, diabetes, or long-term inflammation, several damaging processes affect this middle layer. First, calcium deposits begin to form. Calcium belongs in your bones, not in your arterial walls. But when blood vessels are chronically inflamed, calcium moves from the bloodstream into the tunica media. It crystallizes and forms deposits, making the vessel wall increasingly stiff. Second, elastic fibers start to break down and are gradually replaced by collagen, which is far more rigid and less flexible. Third, smooth muscle cells undergo a harmful transformation. Instead of acting like muscle cells, they begin behaving like bone-forming cells, actively depositing calcium and accelerating calcification in the vessel wall. A detailed review published in the Journal of the American College of Cardiology in 2019 confirmed that this process, called vascular calcification, is the main driver of arterial stiffness and greatly increases cardiovascular risk. By the time a person reaches age 65 with years of poorly controlled hypertension, their arteries can start to resemble bone tissue more than normal blood vessels. They become calcified, rigid, and inflexible, and no blood pressure medication reverses this condition. ACE inhibitors do not remove calcium deposits from artery walls. Calcium channel blockers prevent calcium from entering smooth muscle cells, helping them relax temporarily, but they do not eliminate calcium already embedded in the vessel structure. The calcification remains, and the stiffness continues. So, the key question is, can arterial calcification actually be reversed? The answer is yes, but not through prescription medications. Instead, it requires targeted nutritional strategies that most physicians are not trained to use. The third mechanism involved is nitric oxide deficiency. Nitric oxide is a gas produced by your endothelial cells. Research published in the European Heart Journal in 2012 identified nitric oxide as one of the most critical signaling molecules in the cardiovascular system. When nitric oxide is released from the endothelium, it spreads into the smooth muscle layer of the vessel wall, signaling those cells to relax. As a result, blood vessels widen, blood flows more freely, resistance decreases, and blood pressure drops. A healthy, functioning endothelium continuously produces nitric oxide, helping keep blood vessels relaxed and blood pressure within a normal range. But when the endothelium becomes damaged, especially when the glycocalyx is stripped away, nitric oxide production drops sharply. Blood vessels lose their ability to relax properly, remain constricted, and blood pressure rises and stays elevated. The enzyme responsible for producing nitric oxide is called endothelial nitric oxide synthase, or eNOS. This enzyme is damaged by the same factors that harm the glycocalyx: high blood sugar, oxidative stress, and chronic inflammation. The eNOS enzyme depends on several cofactors to operate correctly. The most important is a molecule known as tetrahydrobiopterin, or BH4. When BH4 levels are sufficient, eNOS produces nitric oxide effectively. When BH4 becomes depleted, eNOS turns dysfunctional, generating harmful free radicals instead of beneficial nitric oxide. The enzyme is also activated by shear stress, the mechanical friction of blood moving across the endothelial surface. When blood flow increases, this friction activates eNOS. This is one reason exercise helps reduce blood pressure. A 2014 meta-analysis published in Sports Medicine examined the role of isometric exercise training in lowering blood pressure and explored possible mechanisms. The findings showed that isometric resistance training, which involves muscle contraction without movement, is especially effective. The specific protocol studied includes squeezing a hand grip device at 30% of maximum strength for 2 minutes, resting for 1 minute, then repeating this 4 times. This exact method has been shown in multiple clinical studies to reduce blood pressure by 8 to 12 systolic points after 8 weeks of consistent practice. Now the fourth and final mechanism, the insulin-kidney connection. This explains why lowering sodium intake often does not work for most individuals with hypertension. Your kidneys regulate blood pressure by controlling sodium balance. However, this system depends entirely on the kidney's ability to respond properly to sodium intake. Here is the key issue. Insulin blocks sodium excretion by the kidneys. When insulin levels remain chronically elevated, the kidneys retain sodium regardless of how much is consumed. Research published in the New England Journal of Medicine in 1987 showed that insulin resistance is present in essential hypertension and plays a direct role in raising blood pressure. Insulin affects the kidneys through several pathways. First, it directly increases sodium reabsorption in the proximal tubule of the nephron. Greater reabsorption means less sodium is excreted in urine and more is kept in the bloodstream. Second, insulin activates the sympathetic nervous system, causing the kidneys to release renin, which triggers a hormonal cascade, resulting in aldosterone release. Aldosterone signals the kidneys to retain sodium and excrete potassium. Third, insulin raises the sensitivity of blood vessels to angiotensin II, a powerful vasoconstrictor. A landmark 1991 paper published in Diabetes Care demonstrated that insulin resistance is a multifaceted condition responsible for hypertension, obesity, dyslipidemia, and atherosclerotic cardiovascular disease. This explains why individuals with insulin resistance, prediabetes, or type 2 diabetes almost always develop hypertension. Elevated insulin keeps the kidneys in a constant retention state. And here is what many people overlook. You can have significant insulin resistance without having diabetes. Your fasting blood glucose may appear normal. Your hemoglobin A1C may also be within range, yet insulin levels could still be elevated, and that increase may be silently driving hypertension. Most physicians do not routinely measure insulin levels. They measure glucose and A1C. If those come back normal, they assume insulin function is normal. That assumption is incorrect. Now, let me walk you through the complete 4-step protocol to reverse these processes. The first step is restoring the glycocalyx. To begin, you must stop damaging it. The main factors that harm it are high blood sugar and oxidative stress. Every time blood sugar rises above 145, It injures the glycocalyx through a process known as glycation. So, step 1 is stabilizing blood sugar. This is not only about avoiding diabetes, but about keeping post-meal blood sugar consistently below 140. For most individuals, this requires significantly reducing refined carbohydrates, not eliminating all carbohydrates, but selecting those that do not sharply raise blood sugar. Focus on whole foods, non-starchy vegetables, legumes, and some fruits, while avoiding sugar, white bread, white rice, pasta, and baked items. Second, you need to supply the building blocks your body requires to rebuild the glycocalyx. The glycocalyx is mainly formed from molecules called glycosaminoglycans, which are long chains of sulfated sugar compounds. The best dietary sources come from sulfated polysaccharides found in seaweed, particularly fucoidan from brown seaweed. Research indicates these compounds help restore glycocalyx thickness and improve endothelial function. Supplements containing fucoidan are available, and studies showing benefits typically use doses between 600 and 1,000 milligrams daily. Third, it is essential to significantly reduce oxidative stress. The most effective antioxidants for vascular health are polyphenol found in colorful vegetables and fruits, such as berries, dark leafy greens, beets, dark chocolate, and green tea. These foods contain compounds that neutralize free radicals before they can damage the glycocalyx. Consider a 71-year-old with hypertension for 13 years taking 2 medications. Blood pressure was controlled at 130/82, but lab tests showed elevated markers of endothelial dysfunction. The individual began a protocol, eliminated all refined carbohydrates, added a fucoidan supplement at 800 milligrams daily, and greatly increased intake of polyphenol-rich foods with 1 cup of mixed berries and 2 cups of leafy greens each day. After 12 weeks, endothelial function tests showed dilation improved from 5% to 13%. Blood pressure dropped from 130/82 to 116/74. One medication was reduced, and after 6 months, both medications were discontinued. Blood pressure remained stable at 120/76. Now, step 2, decalcification, removing calcium from artery walls and restoring flexibility. Many people believe that once calcium builds up in arteries, it is permanent and cannot be reversed. This belief is incorrect. The key protein involved is matrix GLA protein, or MGP. This protein works like a traffic controller for calcium. When MGP is properly activated, it directs calcium into the bones where it belongs. When it is not activated, calcium moves into the arteries and deposits in vessel walls. MGP is activated by vitamin K2, specifically the negative 7 Malawian Quachus form. Research published in Atherosclerosis in 2009 found that higher dietary menaquinone intake is linked to reduced coronary calcification. The Rotterdam study, published in the Journal of Nutrition in 2004, showed that dietary menaquinone intake is associated with a lower risk of coronary heart disease. Without sufficient vitamin K2, MGP remains inactive, allowing calcium to accumulate in arteries. With adequate vitamin K2, MGP becomes active, redirecting calcium away from arteries and into bones. This process can help reverse arterial calcification. Studies demonstrating benefits commonly use doses of 180 to 360 micrograms daily of negative 7 Malawian Quachus. However, vitamin K2 alone is not enough. Calcium also requires vitamin D to effectively enter bone tissue. Vitamin D increases calcium absorption from the digestive system and supports its integration into the bone matrix. Therefore, both nutrients must work together. The third component is magnesium. Magnesium acts as a natural calcium channel blocker. When magnesium levels are sufficient, it prevents calcium from entering smooth muscle cells and vessel walls unnecessarily. When magnesium is low, calcium enters these cells, causing vessels to constrict and blood pressure to rise. Magnesium also helps prevent calcium from crystallizing and forming deposits in vessel walls. Many people are deficient in magnesium because it is primarily found in dark leafy greens, nuts, seeds, and whole grains. Several factors further reduce magnesium levels, including chronic stress, alcohol use, diuretic medications, and proton pump inhibitors used for acid reflux. The solution is magnesium supplementation using highly absorbable forms such as magnesium glycinate or magnesium threonate. These forms are well absorbed, and the recommended dose for cardiovascular support is 400 to 600 milligrams daily. Consider a 74-year-old with hypertension for 18 years, taking 4 medications. Blood pressure was barely controlled at 136/86. A CT scan showed significant calcification throughout the aorta. The individual started a decalcification protocol. Vitamin K2 at 360 micrograms daily, vitamin D at 6,000 international units daily, and magnesium glycinate at 600 milligrams daily. After 6 months, a CT scan showed the calcification score decreased by 9%. Blood pressure dropped to 122/78, and medications were reduced from 4 to 3. After 1 year, the calcium score decreased by 16%. After 18 months, the individual was on 1 medication with excellent blood pressure control. Now, step 3, nitric oxide restoration. First, protect and increase BH4, the essential cofactor for the eNOS enzyme. Make sure you get enough folate, vitamin C, and vitamin E. These nutrients help restore BH4 and prevent eNOS uncoupling. You can get folate from dark leafy greens, vitamin C from citrus fruits, berries, and bell peppers, and vitamin E from nuts and seeds. Research published in the Journal of Cardiovascular Pharmacology in 1999 showed that oral vitamin C can reduce arterial stiffness in humans. Second, stimulate eNOS through shear stress. One of the most effective ways is isometric hand grip training. Squeeze a hand grip device at about 30% of your maximum strength for 2 minutes, then rest for 1 minute. Repeat this cycle 4 times, and do it 4 times per week. Third, practice nasal breathing. Breathing through your nose instead of your mouth allows your nasal passages to produce nitric oxide. Studies have shown that nasal breathing can raise blood nitric oxide levels by up to 400% compared to mouth breathing. Now, step 4, the insulin reset. This step helps your kidneys function properly so they can remove sodium effectively. High insulin levels keep your kidneys in sodium retention mode. To fix this, you need to lower insulin levels. The most effective approach is time-restricted eating. This means limiting your daily food intake to a set window and fasting for the rest of the day. For individuals with hypertension, a 16-hour fast with an 8-hour eating window is recommended. Eat all your meals between noon and 8 p.m. and fast from 8 p.m. until noon the next day. During the fasting period, you can drink water, black coffee, or plain tea. No calories. Research shows that time-restricted eating can reduce systolic blood pressure by 9 to 11 points within 8 weeks, without changing what you eat, only when you eat. This works mainly through insulin control. Lower insulin unlocks the kidneys, allowing proper sodium excretion and leading to more stable blood pressure. You also need to improve insulin sensitivity at the cellular level. The most effective way to do this is resistance training. When you perform resistance exercises, your muscles develop more insulin receptors. Studies show that training 2 to 3 times per week can lower fasting insulin by 20 to 30% within 12 weeks. This is what true hypertension reversal looks like. It's not about temporarily managing symptoms or controlling numbers with medication. It's about correcting the underlying causes. Glycocalyx restoration, arterial decalcification, nitric oxide production, and insulin normalization. These 4 steps target the real drivers of hypertension. When you address the root causes, blood pressure can normalize naturally. Your body has the ability to heal when given the right conditions. Start with 1 step. Choose the one that fits your situation best. If your diet includes refined carbohydrates and sugary foods, begin with glycocalyx restoration by stabilizing blood sugar. If you are overweight or show signs of insulin resistance, start with the insulin reset using time-restricted eating. If you are not physically active, begin with nitric oxide restoration through isometric training. This is not a recommendation to stop your blood pressure medication suddenly. That would be unsafe. Medications help manage symptoms, while these strategies address the root causes. In the beginning, you may need both. Start applying these methods while continuing your current treatment. As your blood pressure improves over time, work with your doctor to gradually reduce medication under proper supervision. Monitor your blood pressure daily at home and observe the trends. When your readings consistently improve and remain stable, Talk to your physician about adjusting your medication. Never stop medication abruptly or change doses without medical guidance. However, don't assume you will need medication for life. Traditional medicine often focuses on managing pressure levels rather than reversing vascular damage. But now you understand more. You know about the glycocalyx, arterial calcification, nitric oxide, and the insulin-kidney connection. When you understand these mechanisms, you can begin to correct them. This is the difference between managing and reversing. Managing often means lifelong medication. Reversing means repairing the structure at the cellular level. These four mechanisms drive hypertension, yet standard care does not fully address them. Medications may lower pressure temporarily, but they do not fix the underlying damage. That repair is possible. Restore the glycocalyx through blood sugar control, sulfated polysaccharides, and antioxidants. Support decalcification with vitamin K2, vitamin D, and magnesium. Improve nitric oxide production through shear stress exercises and nasal breathing. Reset insulin with time-restricted eating and resistance training. When you correct these mechanisms, blood pressure can return to normal, not because it is being forced down artificially, but because your vascular system is functioning properly again. You now have access to information that many physicians may not fully apply or emphasize. Information that could help reduce dependence on medication and lower the risk of becoming one of the 675,000 Americans who die each year from complications related to hypertension. Use this knowledge. Apply it. Start today. Subscribe to this channel for more medically grounded insights designed to help you stay healthy and avoid serious interventions. Take care of your blood vessels. They are essential for life. Hypertension is not always a permanent condition. It can be reversed if you understand the mechanisms and take consistent action. The decision is yours. Choose reversal over management.